Good evening, everyone. I think Dr. Nalini really set the stage, okay, by by explaining how the hormones help during performance, and therefore no wonder that many of these hormones and other substances are used to enhance performance, and that is what the next topic is all about: performance enhancing drugs. So Dr. Sowrabha here, I think will set the discussion forth. If we can get the slides. Okay. We'll need a mic and something to. Yeah. Okay, so you'll stand.
One more mic.
So, and let Sowrabha, you can stand here.
Yes.
So,
Click for pointing.
Sowrabha, what are these performance enhancing drugs? I think she'll start the discussion. What is meant by performance enhancement?
So good afternoon, everyone. I'm very happy to present this duologue with ma'am, Beena Bansal ma'am. So let's begin. Already Dr. Nalini has set the stage for this topic. She's already mentioned the physiology and the hormones involved in sports. So when too much is too bad, that's when abuse happens. Misuse is inappropriate use, while abuse is using in excess for the wrong indication. It can be unethical. So what are performance enhancing drugs? These drugs are used to improve appearance by building muscle mass or to enhance athletic performance. Actually, we've always known them as performance enhancing medication. But then there is a newer and better terminology now. It is called appearance and performance enhancing medication drugs. That is because what we see in athletes or what we hear, what comes to our mind when we think of performance enhancing is only athletes and weightlifters maximum. But that is only the tip of the iceberg. Below that, we have a huge number of people who are abusing it just to build their body and their image. So this has become a big social problem now. So the global prevalence is actually, it's just an estimate because it is underreported. Anabolic steroid abuse should be self-reported always. So we see very few patients coming to us. So it's around 6.4% in men and about 1.6% in women.
So I agree, Sowrabha. So when we talk about elite athletes, Olympic athletes, and they using these drugs as performance enhancing drugs, it's a very small percentage. But what we see in practice, and I'm sure everyone here must have realized that there are a lot of mainly men and boys coming with asking for prescriptions. In fact, for testosterone, HCG, they already know the drugs. Many of them are already on supplements, so-called supplements, which have lots of these drugs under the garb of supplements. So unless we are aware of this, and there is a big role of physicians and endocrinologists to kind of address this issue, which is almost becoming a huge social problem because it leads to a lot of problems. So let's see what these drugs are.
Yeah. So coming to the types of appearance and performance enhancing drugs, we have the most commonly abused, that is the anabolic androgenic steroids. Then the next set of group, I'll be coming to detail in later on. The non-steroidal anabolics, that is insulin-like growth factor and growth hormone. There are erythropoietins and stimulants. In fact, caffeine also is one of the stimulants, which I have not mentioned here. Glucocorticoids can be abused, and there are thermogenics, that is including thyroid hormone. Actually, we think only of anabolic androgenic steroids, but I would just like to mention on a lighter note here, although we read and know so much about this, in a hospital where I was working in Bangalore, so a nephrologist had come, a urologist had come to me saying, Sowrabha, can I use a little small dose of thyroid hormone? And he's so slim and fit, just some amount of central obesity. So he said, will that fat go away? So I was horrified. He actually considered taking it. So it's not that uncommon. Also in the pool where I used to swim, I heard that some competitors changed their coach because some of those students were given some powders, those competitive swimmers. So unlabeled, in unlabeled containers, they would just give them and say, you just use it, you'll start winning medals. So they left that coach. I don't want to mention names, but they are very well-known coaches. So it's quite horrifying how they procure this. So what are masking agents? Just briefly about it. They are supposed to interfere with the analysis of doping agents, that is performance enhancing substances, and diuretics. So diuretics can be used to lose weight and fall into an underweight category also, and also they can help in reducing the detection levels. So
okay, so I'll just quickly put in a historical perspective. I think we have not much time left now. So the whole story started, in fact the story is quite old. The doping is not a new phenomenon. Physicians and athletes have been using all these drugs for many years, but there was a state-sponsored doping which happened before the Berlin Wall fell. So 1956 Summer Olympics, and there were like lot of athletes, the performance of those German athletes, including women. So I think let's put in that gender thing here. Where does women come in this whole picture? Because all we see are men and boys taking these anabolic steroids, but those were the competitions where women athletes really perform well, at the cost of all those virilizing side effects. So there it was realized not just that doping is a big phenomenon, and after that there were rules set in to check for doping, but also after that there were rules set in to check, to affirm the sex. A sex passport was required. So it led to a little murky area of something like, and the way sex determination was initially done was external examination. So you can imagine what kind of humiliating experience that must have been. Later on, there was this bar body testing done to see number of X's. All the fallacies of checking number of X's. For example, a Klinefelter will be labeled as a female because XY is there. Whereas XY and complete feminization syndrome will be labeled as despite being completely female. So there were issues with those, but bar body testing was done, and it led to really social castration of very famous athletes. We know historically the women athletes who were kind of put under the radar, and socially the awards were taken and the humiliation they suffered. So this is how it all started. The story goes on. I think I'll stop and you can take it forward, but quickly we'll go through the next slides.
So just briefly about, do they actually enhance athletic performance? We classify all of them as performance enhancing, but they not all do. What is the evidence that we have? When we did a literature search, there is very little evidence on this, exactly the effect. But then I would like to mention one article published in the Sports Medicine Journal, where the World Anti-Doping Agency, that is the prohibited substances, they did a study where they found that of the 23 substances, every year they publish a list actually of prohibited medications, prohibited drugs. Some of them will be in competition drugs, that is during competition they are not supposed to be detected. Some are in and out of competition, which affects the muscle from a long-term point of view. So we have that list freely downloadable actually. So among all the 23 substances, evidence found that only 5 of them actually increased performance. So anabolic agents in supratherapeutic doses increase muscle strength. Beta agonists are supposed to increase muscle strength and sprint power. Beta blockers actually improve accuracy. For example, in archery or shooting, they are supposed to not be detected during the competition. Glucocorticoids can improve muscle strength. This is actually paradoxical. Some stimulants increase muscle strength. So in short term, they are...
Just quickly mention, it's not just the outdoor sports. Actually, I remember one of my patients who is a master chess competitor, and she was having sleeping problems, but she refused anxiolytic prescription because that is being tested before chess competition. So drugs which can relax you, even those kind of drugs which are also probably in this category.
Yeah. So the most coming briefly to the most common drugs of abuse, that is anabolic androgenic steroids. So there are more than hundreds of these. If we look at the list, how are they different from testosterone? Is testosterone has both androgenic and anabolic effects. So these drugs have predominant anabolic action. So what was for a long time found was that it was debated that supratherapeutic doses of testosterone does not increase muscle strength. That was believed initially because all the androgen receptors are saturated by the physiological testosterone. So even if you give supraphysiological, it doesn't increase strength. But then now we have evidence that it does. So
there is dissociation of anabolic and androgenic activity by making those chemical changes, and also those chemical changes may help mass detection in specific bioassays. So these are various chemical names of the androgenic anabolic steroids, and the differences arises, although androgen receptors are same, there are a lot of post-receptor pathways where this differentiation occurs, and the kind of the response elements which they stimulate later on. So I think we'll move ahead. My thing would be whether we understand the same thing about women or not. So androgenic anabolic steroids, we have enough data on how they improve the performance of men, but we do not have enough data whether they really improve performance in women. With some anecdotal data and those historical, as I said, 1952 Olympics. But same things, because there is a doubt that this may, and there is evidence, all those parts, the same thing applies for endogenous hyperandrogenism. So while exogenous hyperandrogenism we are discussing, what about females with endogenous hyperandrogenism, including polycystic ovary syndrome? So there are trials in PCOS, and if they check testosterone levels, and we know 2 recent cases where checking testosterone levels, the woman was barred from athletic competitive sports. We know a famous Indian example as well. So after that, there is a regulation about testing testosterone level and giving testosterone reducing drugs if they want to kind of just to do that fair play. So inclusivity versus fairness becomes a major issue also in transgender women. Where do we place them? We are still talking in binaries. We are still talking about men versus women because we wanted to have a fair play. Therefore, there is a men competition and women competition. Where does other gender go? Which is not even in the forms. Do they ask? So only Germany is one country where they ask men, women, and other gender in competitive sports as well. So where is that place in all this testing of various doping elements? Where do these endogenous hyperandrogenism women go?
So anabolic steroids are almost abused in 10 to 100 times the dose of testosterone. And then the most common route of abuse is actually shockingly intramuscular, because we know that oral 17-alkylated steroids have a lot of side effects, except probably oxandrolone. So we'll skip this slide. So briefly, they increase.
Dr. Nalini actually did a lot of our job by explaining the effects of these drugs on performance. So we'll skip the mechanisms. Let's maybe wrap it up.
Selective androgen receptor modulators are drugs which are identical, but they have less androgenic effects and more of anabolic effects. So actually in the list of WADA, these were the most commonly found abused drugs. But then there was a recent article where they have studied all the drugs which were abused, and they found, they searched in the net about how we can procure, how these athletes procure it from online sites. So when SARMs was typed, there were so many drugs, so many internet portals from where we could buy them. But then when they studied them, that only less than 50% actually had selective androgen receptor modulators. So the labeling was also faulty. Yes. So they ended up having recombinant growth hormone and
so
PPAR alpha.
It seems one can get supplements online, marketed as supplements, but they actually have SARMs, and it's easily available. So there are a lot of drugs, a lot of supplements marketed as such, but they are actually having these prohibited drugs. So supplements have a different regulatory body, we understand, and that's a major public issue.
So physiology ma'am has already discussed. So we know the adverse effects of growth hormone, erythropoietin is also. And there is indirect androgen doping, that is selective estrogen receptor modulators, anti-estrogens and aromatase inhibitors. So they increase endogenous like LH secretion and indirectly increase testosterone. So they can also be abused. So we already came to this, how common it is. So what we see is only the tip of the iceberg. So, yeah. So what is the Indian scenario? Just briefly, it is, we know very less about this. This is very less talked of, but in this conference, we have 2 sessions on this. So when we went through the World Anti-Doping Agency list, so we could see that horrifyingly, what they mention is actually Russia and Italy were top in the list of nations, nation-wise, but then India actually, this time, it has kind of overtaken. Of course, this is only 1 year's list. Maybe it is even underreported. So many athletes were reported. So I have just, we have just, yeah, these are all the names of the athletes. Yeah.
We understand the side effects of androgens. So keeping in mind the elite athletes are exposed to these side effects, still they prefer to take these dangerous drugs. We'll skip the law and keep it for discussion then. Okay. So I think we'll just open it for discussion if Dr. Nalini can also come here. Okay.
Just briefly about how to screen for abuse. So LCMS is the most accurate method, although we have the earlier ratios, testosterone and the epitestosterone ratio. If it is more than 6:1, now it is changed to 4:1. Then we have methods to detect growth hormone abuse. Just briefly about gene doping. So this is just a potential speculation only. So gene doping, there are certain target hormones for gene doping, and yeah, take questions because we are running out of time. I think.
Yeah, I think we are already run out of time, so it's open for discussion.
No, for discussion is.
ACMS says that for a moderate intensity exercise, in someone who doesn't have a cardiovascular disease, they can outright be prescribed an exercise of divided activity of 15 to 20 minutes each in small spurts, 15 minutes in the morning, afternoon, night, that way. So ACMS says that for moderate intensity activity, even ADA says that we need not evaluate the patient first. We can start the small level activity that also yields benefits. So for anything that goes to the level of anaerobic training or HIIT, definitely a cardiovascular screening is essential, because we do not know whether the patient is harboring any blocks or not. We do not know anything unless and until we evaluate the patient cardiovascularly. It's very essential before going to high intensity training that the patient is evaluated by a cardiologist. And also it's important that a professional registered physiotherapist is involved whenever exercise regimen is given. The first recommendation should always come from the physiotherapist. We sit in team. In our practice, we sit as a team whenever we are giving endocrinologist, physiotherapist and nutritionist together, and we start the treatment for the patient in this way. So a physiotherapist should be involved so that there is no injury. Along with increasing aerobic activity, it is very well known that resistance training improves HbA1c, in fact much more than aerobic training, and resistance training needs to be done around 3 times a week only with 1 day gap. So these small principles have to be told, and this does not require any evaluation. For HIIT, yes, a cardiovascular system needs to be evaluated by the cardiologist.
What does your prescription looks like for exercise?
My prescription has less of writing, more of speaking.
Achha.
I spend about 15 minutes to 20 minutes with the patient, and then we talk a lot. We discuss the problems related to exercise, and then I write.
One question for the Duologue team. So what about the long-term health of these athletes? You know, what happens when they hit their 40s and 50s? Because this is all in 20. Yes. What happens when they hit their 40s or 50s?
Yeah, we have data regarding men. If they have abused it for longer than 1 year, then they may have some withdrawal symptoms like hypogonadism. They may have the various symptoms on the muscle negative. It depends on the drugs that are abused. For example, glucocorticoids have their own effects. Then they may have cardiovascular adverse effects. But basically, the hypogonadism, they say if it's abused for more than 1 year, then we have to slowly taper it, the doses, and then.
So the immediate effect is number one, addiction, which happens not immediately. It's not immediately addictive, the anabolic steroids in men, but there is data on long term. If they are taking it for a long time and when they withdraw, there is depression, because while they are taking it, they have that aggression, risky kind of a behavior. And also there is worsening of muscle dysmorphia. That is the terminology. The problem is there is a whole new population, young population who are taking it, and when they reach their 50s, the data is yet to come because it's a long-term thing, but definitely looking at surrogate markers, it seems that there will be a lot of, because the doses are 10 to 100 times the ones they are taking, and although anabolic, if like it's mainly anabolic, so we still don't know as much as how safe they are.
Exactly like psychological abuse drugs, but then they lose the muscle, so they go into depression. So when they are using it, they have a mania phase. Then later on, eventually they have depression. So they tend to go back and reuse them. So it's very difficult.
If I may add to that, while the athlete was abusing earlier, now the athlete is no longer training. So there is a high intake which remains, but then the expenditure doesn't happen. They go into muscle wasting, they end up in injuries as well. They end up in obesity. We see many of the previous athletes now who've turned 40, 50. We see them obese most of the times, abnormally obese. So this is because the intake doesn't stop, but then their workout, their exercise comes down, their muscle tone comes down. Research says that as much as 48 hours of lack of exercise decreases the muscle ability. So for years together, they have done and they have stopped for years together. So it's not just the drugs, but it's their lifestyle also which has changed.
Hi. I just have a question that lately we have seen in the news that many of the celebrities, they exercise and then they end up in death and they die. So what can be the reason for that?
Yeah,
Like,
and
is
we
it
get panic
related to
messages on
this?
WhatsApp that someone has got a stenting done recently. Literally, people are messaging about
So
that.
is it related to this? Yeah.
So the most important thing we need to understand is we are seeing only one facet of their life. What are the other facets which we are not seeing, right? It's important how the stress is being handled. What are the other addictions that these women go through? So the famous celebrity who apparently had a heart attack and underwent stenting at under 50 age is supposed to be a fitness icon, but then she's a smoker. We all know that smoking is a risk. She's an alcoholic. They take a lot of stress in their lifestyle. They have bad circadian rhythms. They sleep at abnormal times, eat at abnormal times. Will that not impact the life? That's a question which is open for discussion and often ignored. Probably answers lie when we answer all these questions together.
Does the choice of supplement they use as a pre-workout or post-workout?
It might be there. I think that is the underlying thing which we feel, that some of these examples where the person is dying while exercising, we don't know what all other things they're using.
Or maybe they are not so considerate about what to take pre-workout or dehydration or something like that can be happening.
So these are just case reports. Taking information out of that is very difficult. So someone needs to. So exercising will not, in long run, unless there is an underlying cardiovascular dysfunction, it should not cause any problem. So whenever we are advising exercise, any exercise is better than no exercise. Exercising more is not going to harm if you're using all those safety precautions. I think we still need to emphasize the importance of activity and exercise, like defined differently, physical activity versus exercise versus different types of exercise versus moving more, sitting less. These are all different parts of the whole thing which we call as exercise. These may not be the same thing. So the benefits are definitely much, much more than these small case reports creating the panics of the ill effects of exercise. Yeah.
Absolutely agree with Dr. Beena. exercise, that is very important. Just because we are seeing a rare case which is happening and it is coming into limelight that some so and so social media prominent person is dying, has died because of exercise, that doesn't mean that we just say, I'm going to sit in my chair, I'm not going to get up. We cannot use it for defense and say we are going to lead a sedentary life. We know that being sedentary is the new smoking. Smoking is considered a very risky thing. We know that it is risky. So exercise is essential. Caution should be borne in mind when we are not dealing with other things like sleep deprivation, stress, food habits, and also other addictions like smoking. If they're all there, we need to be cautious a little bit before we jump into the high intensity exercise activities.
And exercise has been very, very robustly shown to reduce mortality. When someone starts moving from 1,000 to 2,000 steps, 2,000, every 2,000 step addition, there is a reduction in mortality till 8,000 steps for sure, even till 10,000 probably. So there is no doubt that the evidence of exercise helping in reducing complications and mortality is much, much higher, and these are just some case reports where we don't even know the cause and effect.
What we meet in social media is judgment. Coming to an inference technically is very tough with limited data from these patients and case reports. So exercise, that's a good thing.
Hi. Hi.